and today I have a good one. This one is so hot off the press in terms of practice-changing information, it hasn't even been published yet. This is information I got from a recent conference. We go to conferences every, couple times a year to check out what the newest findings are, and this is all about the newest treatments for muscle-invasive bladder cancer. Now, I know if you're not a muscle-invasive bladder cancer patient, it doesn't sound that interesting. It's actually extremely interesting. It's a complete practice change, and you can see how medicine evolves. You see the data that we look at and how we look at these things to get to our conclusions and how we evolve medicine. So this is kind of a look under the hood. Let's jump into it. So here we have a publication, or actually a series of PowerPoints. This is by Dr. Galsky. Forgive me if I got the name wrong, but he presented this at the Genitourinary Society meeting called GU ASCO. This is a society meeting for cancer specialists. And here we talked about the use of a new medication combination for people with muscle-invasive bladder cancer and how that combination can be used before someone has a bladder removal to improve their odds of cure. And I'll bury the lead, this new treatment is way better. So let's kind of go into it. The patients were divided into two groups. Control group got chemotherapy. And this is not just any chemotherapy, it's a pretty strong combination of chemotherapy. It's been tested for many years and was the standard of care for like the last decade plus. And that's called cisplatin gemcitabine. This, for many, many years, was the best treatment we can give someone before removing the bladder from muscle-invasive bladder cancer to cure them. So basically old school chemo. And now the new combination is two new medications. One is called enfortumab vedotin. We often call it EV for short. And this is actually an antibody attached to chemotherapy, and the antibody targets the chemotherapy to the cancer, then drops the payload. So you get more targeted release, hopefully more effective treatment. And then the second is pembrolizumab, which is a really widely used immunotherapy now. And it's a PD-L1 inhibitor that basically allows the immune system to kill cancers more effectively. And so patients either had the chemotherapy or the combination of EV plus Pembro. And notably, the Pembro continued after the surgery. And as you all know, for people with bladder cancer that grows into the muscle of the bladder, the current standard of care, or the thing that leads to the highest odds of cure, is actually removing the entire bladder. And if we give someone chemotherapy or treatment beforehand, we can even improve the odds even greater. And so chemo historically would increase the odds of curing someone by about 5%, meaning out of 20 people, you'd cure one more person. But this is really what you want to know. And this is just jumping right to the information. Is what was the rates of disease-free survival? In this case, they call it event-free survival. So meaning, what was the odds that the patient had after they got this treatment and then had the bladder removed? So this treatment before, they got treatment beforehand, bladder removed, and then if they're in the EV Pembro arm, they kept getting treatment for a year. And if they were in the chemotherapy arm, the cisplatin arm plus gemcitabine arm, they just got chemo and then surgery. And you can see that the patients that got the enfortumab vedotin at 12 months and 24 months had substantially higher rates of living without the cancer becoming detectable again. It's a big deal. So they went from a 75% odds of being free of disease to an 86% odds of being free of disease at 12 months, and at 2 years from 66 to 79%. This doesn't sound like a lot, but it is huge. I mean, you're going from basically, instead of 1 in 20 people being treated and having a benefit, 1 in 5 people treated and having a benefit. It's a huge difference, to the point that the rate of disease coming back was reduced by 47%. Pretty big deal. So the next thing we want to know is this true for all groups? Like, are some patients more likely to have this benefit than others? Like, are women more likely to get it than men, or certain races, or certain tumor markers that they may have? And this study basically shows that for almost every group, outcomes were better or favored the EV Pembro arm. This is huge. It means that this EV Pembro combination is pretty much better in almost every scenario. The only scenario where it may not have been better was in the patients that were only muscle invasive with no suggestion of deeper invasion. But you also got to remember that was a relatively small group. So that means that there's less data for them to analyze, so they have less certainty. So you end up with these wide error bars, which mean that we didn't have a ton of patients that fell into this group, so we can't make very strong conclusions. I suspect if we had more data, these bars would be narrow, and even this group would have a benefit. But in this case, we don't know for sure. What we do know for sure is that for patients with nodal metastasis, which is what N1 means, or T3 or T4 disease, or cancer growing in beyond the muscle of the bladder and deep into fat or other organs, they definitely did better. No doubt about it. So if the cancer had spread or the cancer was really advanced, this was definitely a better treatment. Regardless of age, people did better. Regardless of gender, people did better. Regardless of race, people did better with this treatment. It's a pretty big deal. It's a pretty exciting finding. And then you want to look at survival. So like the first thing you look at is, okay, did this have an effect in terms of imaging findings? But did it actually change the odds of someone being alive years down the line? And actually it does. So you're looking at survival benefits here. At 12 months, 4% more patients being alive. At 24 months, 5% more patients being alive. And really out here, these longer time points, these are long-term cures potentially for some people. Likely they are. And as we see lines get really flat like this at the end, that means that people are getting to the places where cure becomes possible and actually quite likely. So here we're seeing a delta of almost 10% difference between the two groups. So it's really, really significant. So if I were a person with muscle invasive bladder cancer right now, I'd probably be on this treatment. This would be the treatment I'd be looking for. And it's the treatment I'm sending many of my patients to get, which is a combination of enfortumab vedotin plus pembrolizumab, because it currently is the best treatment we have for muscle invasive bladder cancer before a cystectomy. And then the really exciting thing for surgeons like myself is seeing how this treatment affects the tumor inside the bladder. Like, does it make them shrink? Does it make them go away? And this is really interesting. So here we're seeing that when people get this combination of EV Pembro, the rates of complete response are 56%. You don't know what that means. Let me explain. A complete response is where something is seen on imaging or on cystoscopy when a camera is put inside the bladder, and then they get their treatment, and then afterwards they have their bladder removed to try to cure them. The pathologist then looks at the bladder under a microscope and sees if they can find cancer. If the pathologist cannot find cancer in the bladder after this treatment, that is what's called a complete response. And when people historically have had complete responses, their odds of being cured of their disease are much higher than those who did not. And so here we're seeing that the rates of complete responses almost doubled from chemotherapy, from 33% to 56%. Like, it's not truly a doubling, but pretty close. And it's a really substantial improvement. We're talking about over half the people having a complete response to treatment, meaning we can even see the cancer once they have their bladder removed. That's very exciting. And I'll tell you, if I were a patient and had this finding at the time of my cystectomy, I would be very happy about that, because it would mean the higher odds, most likely, of me remaining disease-free over time, and that my cancer happened to respond very well to the treatment. So it's pretty exciting stuff. And what this also means is it opens up the possibility for us to start to explore the chances of maybe saving people's bladders, maybe skipping the bladder removal entirely in some unique situations. Now, I got to be clear, we don't know if that's going to work yet. We haven't done clinical trials that reliably show it. We've tried doing clinical trials like this with chemotherapy, with the people with complete responses and trying to save their bladder, but unfortunately many of them still do recur, because shrinking the tumor to a degree that it can't be detected anymore is not the same as eliminating all the cancer. Sometimes you just make it so small it can't be found, but the cancer can still be there and over a long time can recur. So we're investigating this and clinical trials are coming, but this is the really interesting thing is, are these people really free of disease? And if they are, can we save their bladders? And that's where we are. That's the thing we're exploring. It's quite exciting. Not only are outcomes going to be better now, but in the future, we may be able to avoid or de-intensify surgery over time. Now, of course, everything has side effects. This is the thing about honest medicine, is that you not only report the benefits, but you report the downsides. And we have to balance these things as we make choices. And here we see the adverse events associated with EV Pembro and GemCis. And the first thing I'll point out is the rate of any adverse event or anything, any complaint essentially that the patient would have in the study. Both groups had all the patients having at least some complaint. And in medicine, we then need to kind of filter out this information to see which ones were the really bad issues that required some intervention versus just things that affected quality of life or were annoyances. And that's when we look at things called grade 3 adverse events. Generally speaking, these are adverse events where the doctor has to do something to help the patient or treat the symptoms. And you can see that even those are really high. The patients who had EV Pembro, around 75% of them had adverse events, and the Gem-Cis population, around 67% of them had adverse events. So in this particular study, the adverse event rate was a little bit higher with the EV Pembro group than the Gem-Cis group, though they were about the same ballpark. This is another way to look at the distribution of side effects, and we'll see that the side effects generally are different between EV Pembro and Gem-Cis. And with EV Pembro, there's very high rates of rash or itching. Diarrhea was pretty common. Hair loss was more common with EV Pembro. But things like anemia were far more common with traditional chemotherapy. Nausea was more common with traditional chemotherapy. And low white blood cell counts were much more common with traditional chemotherapy. So you can see that the side effect profile, while side effects are common in both, some of the more severe or concerning side effects here, and here were more common with traditional chemotherapy. And a lot of sort of less dangerous side effects were seen commonly with the EV Pembro, though very rare severe side effects were possible. So what I want you to take from this is that if you've been diagnosed with muscle-invasive bladder cancer and you're looking for the absolute current best treatment possible, the treatment will be enfortumab vedotin plus pembrolizumab, also known as EV Pembro for short. The issue here is this is super new. So new that this publication isn't even out yet. This is just the data that was presented at the medical conference. So for those of you who are seeking this treatment, sometimes insurance companies don't have the treatment on their formulary yet. They don't approve it yet. But once this publication comes out, which should be hopefully within a couple of months, it should change the landscape. And if you can demonstrate yourself to be eligible for this treatment or get access to the treatment, this would be the kind of current optimal treatment strategy. So there we are again, another little piece of information to help people go from a place of uncertainty to more certainty with better information to get the best cancer treatment possible. So we can do cancer treatment better, which is ultimately the whole point of this channel. If you found this helpful, please do like and subscribe. Share it so that other people can get access to this information, because ultimately your interactions with these videos, your likes, your shares, your comments, your subscriptions, that's what makes the video grow and get out to other people, and I can help more people that way. So please do what you can. And of course, I'm happy I could be here to help. I look forward to the next one. Talk to you guys later.